Welcome to PodcastRx, a production of Diamond Pharmacy Services. This is a show about pharmacy, but don't let the title fool you. While we definitely talk with pharmacists about medication topics, we also sit down with nurses, technicians, and other pros to discuss relevant issues in corrections health, long-term care, and so much more. Whether you're a pharmacist, a practitioner, or just find these things fascinating, this is a show for you. On this episode, regular contributor Chris Bender from Diamond's Drug Information Center gives us a much-needed break from all the COVID talk to discuss another serious, if understated, problem in healthcare: polypharmacy. Chris breaks down what exactly polypharmacy is.
I really tend to frame polypharmacy simply as using more medications than would be clinically necessary.
Its negative effects on patients and healthcare as a whole.
Other estimates show that polypharmacy-induced hospitalization is responsible for $30 to $180 billion annually.
And what pharmacists can do to stop it.
The first safeguard really is listening to the patient.
Along the way, we also talk about the prescription cascade, deprescribing, and managing polypharmacy in corrections and long-term care settings. All this and so much more on PodcastRx. I'm Adam Campbell. Chris Bender, thanks for coming back on PodcastRx once more. I feel like we should present you with a certificate or something. You've been on the show so much and been so helpful as a guest.
Well, Adam, thank you so much for having me. And while I would take my honorary punch card, buy four, get one free, I just want to say it's always, a great opportunity to come on, join the pod and discuss, interesting topics with you all the time. So appreciate you having me.
We can't say enough about, again, how much we appreciate you being on here. So, we've been talking a lot of COVID in recent episodes. So today we're going to step away from that. And we're going to talk about another serious, yet low-key by comparison issue in everyday and institutional health, and that is polypharmacy. Now, looking at that term, the layperson may assume it refers to going to too many pharmacies at once. CVS over here, Rite Aid across the tracks, and then the Health Mart 2 towns over. That's not quite it, of course. So, Chris, could you describe the issue of polypharmacy for us?
Absolutely. So, like you said, I'm sure we could all use a break from the typical COVID discussion. So, I'm actually really glad that we chose to discuss polypharmacy today, and that's because it's really too prevalent in today's society. So, to start, I think we really need to define what polypharmacy is. And while there's not really a gold standard definition, the general consensus is that polypharmacy is the use of 5 or more medications. Now, obviously, this is a fairly simplistic definition, and essentially that's because it doesn't take into account many different patient-specific considerations. So, in other words, the way I think of it is that not all polypharmacy is the same. So, for example, if an individual who takes no medications goes to the hospital with a heart attack, for example, then that person will usually be leaving that hospital on around 4 or 5 medications right then and there. And then this person will be taking most, if not all of those medications for the rest of his or her lifetime, of course. So from that example, it's easy to see how a person with either chronic conditions or a major event like that can pass this, 5 medication threshold quite easily.
Yeah, for sure.
So that's why, whenever I discuss polypharmacy, I really tend to frame polypharmacy simply as using more medications than would be clinically necessary. And by framing it this way, we're able to kind of separate out the appropriate cases of polypharmacy, such as would be, our individual in the previous example, from the more inappropriate cases of polypharmacy. Now, I'd like to circle back to what you mentioned in your question, okay? So regarding the use of multiple pharmacies, because of course we do know that can play a role, especially in the quote unquote inappropriate polypharmacy. We know that it's fairly common that patients use multiple pharmacies, and often this is done to take advantage of different pharmacies' pricing or promotions or getting, fuel perks or stuff like that. But the issue with using multiple pharmacies is the potential for a lack of communication, meaning pharmacy A may not know what pharmacy B is filling, meaning they may be filling another medication for the same patient that may either be a duplication of therapy or possibly an interacting medication. So in either scenario, this lack of communication can result in that patient either taking too much of a medication or having adverse effects, which otherwise would have probably been preventable if these would have been screened by the same pharmacist in the same pharmacy. Of course, this same logic would also apply to patients seeing multiple providers who could possibly prescribe duplicate or interacting medications if there's not a clear method of communication between those two providers, such as if they were to share a patient medical record. So that's why I always think it's essential for patients to be their own health advocate, essentially. And what this is this involves patients keeping an up-to-date list of medications as well as of their healthcare providers. So that way, if the person is using multiple pharmacies or using multiple providers, they can at least review that medication list with their pharmacist or other healthcare providers every time they start taking a new medication.
In your professional estimation, Chris, do you think that most patients do this?
Well, yeah. So I like I said before, a lot of patients like to use multiple pharmacies for the benefits of going to different pharmacies. But with that said, I wouldn't say it's the majority. I know from my days working in retail, we had patients who would go to one pharmacy exclusively, and that's usually out of convenience, mostly, and then you build a rapport with your local retail pharmacist. But I would say that the patient population that this impacts the most would be those uninsured or underinsured, because obviously different pharmacies have different payment methods or amounts that you would pay for their medication. So a person, for example, without health insurance may not be inclined to go to the same pharmacy because their metformin at the pharmacy that they get all their other medications would be $20 a month, whereas if you go over to Walmart, it would be $4 a month. So I would say that patient population would be probably at a higher risk of this scenario.
Understood. And you highlight some issues there that could probably be, an additional 5 or 6 episodes of this show. So
absolutely next time.
For next time. So we'll keep from tracking there. How prevalent do you think polypharmacy is among the general population? I mean, you just talked about one segment of people that could be vulnerable to it. Like uninsured people, are there other segments of the population that are more vulnerable to polypharmacy than others? I'm going to immediately assume senior citizens.
Yeah. So with regard to the overall prevalence, obviously it can be kind of difficult to get a proper estimate, and that's simply because people aren't always great at accurately reporting the number of medications that they're taking. One of the things that complicates accurately reporting the number of medications you're taking is people may forget about the fact that they take certain vitamins or supplements that they take because they don't think about those as medications. But, we in the pharmacy profession, we know that they can contribute to polypharmacy just as much in certain cases as traditional medications. But with that said, it's the estimates that I found, it's estimated that around 10% of the general population takes more than five drugs. Now, to your point, the prevalence is higher, around 30% in the elderly population. And to your question, I guess this isn't all too surprising, right? I mean, me personally, I tend to think of it as walking through kind of like a field or through some brush. So we all know the longer you walk through that field, the more burrs you're going to have sticking to you whenever you come out on the other side. And that's kind of how it works with the elderly, because simply by having more time and having more chronic diseases, they're kind of more likely to come out on the other side taking more medications than the general population, if that makes sense. Yeah, for sure. So I think it's important that we first focus on them. They're the first that come to mind. They're at a higher prevalence. So not only are the elderly population at the highest risk for polypharmacy, but they're also at the highest risk for the negative effects of polypharmacy. And it's important to ask why this is. Well, we know that studies have shown that as you take more medications, the risk of adverse events or effects increases as well. And not only that, but most of us know that as we age, the body starts to slow down a bit. So the body takes longer to metabolize medications and eliminate them from the body. So in older folks, some medications can linger around the body for longer, and over time they can build up or accumulate in the body. And this obviously makes adverse effects a little bit more likely in this patient population. But like we addressed with the underinsured population, it's important to understand that polypharmacy isn't just limited to the elderly population. Essentially, any person with multiple chronic conditions, so for example, patients with chronic pain, diabetes, coronary artery disease, things like that, patients with multiple chronic conditions are at risk for polypharmacy. However, what I would consider an under-recognized population may be individuals with mental health disorders. And we see this a lot on the correctional side of things here at Diamond. Often, these individuals rely on combinations of medications, and those combinations of medications may require frequent switching, at least initially, when the patient initially gets started on those medications, in order to adequately control their disease. So because of all this switching and manipulating of the doses, it's easy to see how some medications may be inadvertently continued when they're actually supposed to be discontinued. In addition to this, some psych medications, such as antipsychotics for schizophrenia or bipolar, they can have side effects, and more prominent side effects than other medications, I should say. And what will happen is that rather than switching to an alternative antipsychotic medications, in some cases, providers may simply add another medication to manage the side effect of the antipsychotic, which is a process known, and we'll be discussing, as the prescription cascade.
Yes, I'm definitely going to ask you more about this prescription cascade. It seems like it's a very easy thing to have happen in the situations you just talked about. But before we get into that, what are the worst outcomes of polypharmacy from a health standpoint and otherwise?
So outcomes can really kind of vary from small sort of incidental events, such as like dizziness, all the way to severe events, such as hospitalization. Now, obviously, as you can imagine, less severe events are more common, but it's important to understand that polypharmacy, the way it works is it often results in many small events stacking upon one another. And this can ultimately lead to larger, more serious events. So let me explain what I mean by this with an example, kind of walk through this with me. So take, for example, an elderly patient with a history of high blood pressure who is being treated with multiple blood pressure lowering medications. Now, this is all fine and good, but we know that the more aggressively we treat blood pressure in the elderly, it comes with a higher risk for lightheadedness or dizziness, particularly when standing. Now, say this same patient was recently prescribed amitriptyline, okay? Amitriptyline is used for depression, anxiety, migraines, or even pain, but it's not usually advised in the elderly because it is well known to be sedating. It can also decrease cognitive ability, and it can lower blood pressure upon standing. So see where this is going. This patient, if they given this combination of medications, begins to experience dizziness when they start to stand, and they have a fall. Okay, so unfortunately, this fall could result in a hip fracture, which would result in a prolonged rehabilitation center stay. And essentially what happens is throughout this process, the individual may never quite get back to the level of mobility that they once had, and they can start experiencing increased levels of disability in their daily life, and even they may even require placement in an assisted living facility. Unfortunately, another another common fact is that hip fractures in the elderly are also associated with higher rates of mortality. So while this may be an extreme example, of course, I use this to show how a simple event can lead to a more significant event. Okay.
Right.
So we also, in addition to the individual patient, let's focus on the health system at large, because we know that polypharmacy can lead to unnecessary hospitalizations. Now, estimates vary to degrees, but a particular study showed that around 15% of hospitalizations were medication related, with polypharmacy being one of the leading causes for these medication related hospitalizations. And I think the most important takeaway from this study was that 33%, so 1/3 of the hospitalizations, were deemed to be definitely preventable. So this is something that can be impacted by healthcare professionals and even people just being their own advocate. Other estimates show that polypharmacy induced hospitalization is responsible for $30 to $180 billion annually. So again, a wide range, but even the smaller number, 30 billion, is nothing to shake a stick at. So polypharmacy can not only significantly impact the individual, like I said, but the healthcare system as a whole, really.
Yeah, most definitely. I mean, those are some staggering figures you cited. I couldn't help think, as you were talking about this, Chris, that the idea of polypharmacy, like if people know about it, it may also make people afraid to take appropriate medications. What I mean by this, and just from personal experience, and I've heard from family members over the years who are just averse to, quote, taking pills for everything. And listening to the hypotheticals that you provided, it seems like this might be a real concern for people. Have you ever encountered this as a pharmacist?
Yeah, absolutely. I mean, I think in our day-to-day lives, we all have people that we know, friends or family, who, like you said, are kind of medication averse. They think that less is better. And to be fair, in some cases, it can be. I mean, I advocate a lot for non-pharmacological methods and treatments when you can. But like I said before, polypharmacy is using more medications than would be clinically appropriate. So why I say that is essentially when I speak to any friends or family, if they have any apprehension to using medications to treat a condition, it's important to understand that they have this open discussion with their physician, because if after an open-ended discussion with your physician, they still feel that it's clinically appropriate, then I would say that's good justification to be using the medication. And obviously, these patients can take, for example, blood pressure. If you are not severe enough off the bat, you can often manage it with lifestyle modifications. But if you were to try lifestyle modifications for a few months and that didn't work, and you go back to your doctor, that's the point where they would say this blood pressure medication is clinically indicated. So I would say that I understand the apprehension. And while it would certainly fall in the vein of what we're discussing today, of sort of like less is more in some cases, there are cases that even after the less is more approach has failed, if you would like to use that term, that it does become clinically appropriate to use medications.
We need to take a quick break from this conversation. While you're waiting, this is the perfect time to follow Diamond on social media. You can find us on Twitter, LinkedIn, and YouTube. And if you're local to our Indiana, Pennsylvania headquarters, you might like to follow our Facebook and Instagram pages for our Diamond Drugs and Medical Supply stores. We welcome your likes, shares, retweets, and comments on all platforms. And now, back to the show.
Now let's go back to that prescription cascade idea for a second. Okay,
Sure.
admittedly, so for some levity here, when I say prescription cascade, I can't help but envision a stream of pill bottles or vials falling over a rock outcropping very gently. But in all seriousness, this process is less like a placid waterfall and more like a runaway train, at least in the worst cases. So how does the prescription cascade get started?
Yeah, so just to add to you, when I'm did this presentation a while back for additional levity, I kept thinking of, I couldn't help but conjure up like bad band names, a play on this phrase, like the mescalate or the medication escalation and stuff like that. But I digress. So to put it simply, the prescription cascade is a process where the side effects of drug A are misinterpreted as an entirely new disease or a new problem, which would result in the prescribing of drug B. Okay. Now, in most cases, the prescription cascade can be nipped in the bud by three key concepts. So, one, having a good understanding of the potential side effects of a new medication. That's key. Two, being able to identify side effects if and when they occur. And three, not immediately adding drug B, but instead looking back, seeing if drug A's dose can be lowered, or in some cases, if we could use an alternative drug altogether. So to understand how this process can occur, let's look back to our previous individual who was on blood pressure medications and who was just prescribed amitriptyline. So as I said before, amitriptyline is usually avoided in the elderly because it can decrease cognitive ability over time, among the other reasons that I mentioned before. But because of this decreased cognitive ability in the elderly, the individual may be misdiagnosed as having early onset dementia. And one of the first medications that's used for this is donepezil. But unfortunately, donepezil, by the way it acts and behaves, it can cause urinary incontinence. So over excessive urination, or inability to control, rather, urination, for which they're then prescribed oxybutynin, which is a commonly used medication for overactive bladder. Now, moving forward, oxybutynin can cause dry mouth and constipation. So then they're prescribed laxatives for the constipation and artificial tears for their dry eyes. So because of one medication, in this case, amitriptyline, it's possible in extreme cases that this individual now takes 3 or 4 medications. Now, if the decreased cognitive ability had been identified as a possible side effect of amitriptyline, then the provider could have considered a safer antidepressant, for example, sertraline, or even considered non-pharmacologic therapies, like I mentioned before, such as cognitive behavioral therapy, which is often preferred as a first-line treatment anyway.
Thinking about your example, the phrase, wow, that escalated quickly comes to mind.
Yes.
But in all seriousness, the prescription cascade is an issue that seems like an issue that can very easily sneak up on a provider and a patient. So what safeguards are out there to prevent this chain reactioning from getting started, and how does the pharmacist fit into all of it?
Yeah. So, and to your, I just want to track back for a second, to your point, these are obviously extreme examples going from 1 to 4 medications, but they serve a more broad illustrative purposes. I would say more commonly, it would result in maybe 2 medications. But if you think about it that way, that's still 1 extra medication than would be clinically necessary. So I like to use the extreme just to sort of drive the point home. But back to safeguards, the first safeguard really is listening to the patient, because if we can get an accurate description from the patient, we obviously have a better chance of identifying what they're experiencing as a side effect, if it is truly a side effect of a newly started medication. So obviously, in order to do this, we have to have a good understanding of what the possible side effects are, which, given our training in the subject, pharmacists are well positioned to do. But obviously, not everyone can know every side effect. So that's why when I speak to nurses or providers, or when I give this talk to nurses or providers, I always recommend keeping a resource handy. There are some that are available as an app on your phone. Epocrates is a good example, and this is one that I even keep handy, because this is a ready source of information and side effects that can even be used at the bedside or during a patient visit.
We'll have to link to that in the show notes.
Yes. Now, pharmacists, of course, can play a proactive role as well. The most common example of this is probably performing monthly medication profile reviews. And this is typically done in the long-term care setting. During these reviews, essentially the pharmacist just screens the medication profile for potentially inappropriate medications. Pharmacists can also be asked to perform reviews in an impromptu fashion, of course, at the request of any provider, at the drop of a hat or the picking up of a telephone. But additionally, dispensing pharmacists, in your traditional retail setting, are constantly screening for drug interactions, and of course, they notify providers when clinically significant interactions are identified.
Now, with all these proactive maneuvers, the most obvious step to address polypharmacy once it is evident is to prescribe less and to eliminate any unnecessary prescriptions. Not surprisingly, this is called, wait for it, deprescribing. So how easy or hard is this process to implement?
Yeah, that's the big question in clinical practice. So, because to be honest, despite the potential negative impact of polypharmacy and how important it is to address, deprescribing is hard. We know this both from a patient and a provider's perspective. I would say the biggest thing is there may be a reluctance on the part of the patient to both to stop medications, simply out of fear that it may worsen a certain condition. It's kind of like the old, if it ain't broke, don't fix it mentality. But there may also be reluctance on the part of the provider too to stop medications, especially if they're prescribed by another provider. Kind of the old "I don't want to step on anyone's toes" mentality, Additionally, my wife is a provider, so I've come to understand how much needs to get done in such a small window of time. What with discussing progression toward treatment goals, vaccines, which is ever present today, overall lifestyle management. And because of this, unfortunately, polypharmacy may not be the most pressing issue during that visit. So I kind of get that from the provider's perspective.
Fair enough.
But that's why, because it's often difficult to stop a medication once it's started, we often refer to this as like clinical inertia or providing inertia. It just doesn't want to move off the patient's profile once it's been there. There's been a movement, a growing movement towards stopping polypharmacy at its source, and this is through more judicious prescribing. The central tenet to this movement is to only prescribe those medications that are clinically necessary, a theme that I've been kind of harping on throughout the earlier portions of this podcast. Essentially, this way of prescribing asks, can this condition be treated with non-pharmacologic therapy? And can this patient's current treatment be optimized rather than adding this additional medication? So in following this practice, there may be circumstances in which the total number of medications can be minimized.
I think that's a great place to take a quick break.
Thanks for listening to PodcastRx from Diamond Pharmacy Services. If you're a fan of the show and have any topics you'd like to hear us discuss, or if you have any thoughts on a particular episode you'd like to share, please email us at podcastrx@diamondpharmacy.com. And while you're at it, please rate and review our show wherever you get your podcasts. Your feedback helps us make the best show possible for you. And as always, we appreciate your feedback and support. Now back to the show.
All right, welcome back to PodcastRx, talking polypharmacy with Chris Bender. Now we're going to switch away from talking about the individual and the community populations to the institutional populations. Of course, this is a Diamond podcast, and we like to talk about the things we do here. So, Chris, I wanted to ask you about polypharmacy and your work in the Drug Information Center. How often are you and your colleagues addressing this issue?
Absolutely. My colleagues and I are involved fairly frequently in polypharmacy discussions. So in my particular role, I'm very fortunate in the fact that I get to work with both sides of the business, corrections and nursing home. On the nursing home side, many of the questions are geared more towards specific side effect, more specific questions like side effects that the patient began to develop, and now the provider is calling to see if that side effect could be medication related. It's usually during these types of discussions where I like to go further than not only just helping the provider determining whether it is indeed medication related, but I also like to discuss alternative treatment strategies if it is possibly treatment related. So we field these types of questions on the correctional side as well, but we also participate in proactive medication profile reviews, like I mentioned before, for certain facilities. So essentially for those facilities, we'll pretty much review the medication profiles of patients taking more than 5 medications on a routine basis in the hopes to identify any interactions or possibly unnecessary therapy.
The medication review is one step you talk about, but what are some of the other routine steps that you take to address the polypharmacy issue in the jails, prisons, the long-term care facilities?
Yeah, so, and I think this goes to the larger, how do you address polypharmacy in general? Not just me, but I guess any provider could really think this way. So I kind of break it down as first, we have to have a complete list of the patient's medications. Like I said before, some patients will forget that they're taking vitamins and supplements. So make sure that the list of medications includes both vitamins and supplements. We also need to complete a thorough patient medical history, meaning what diagnoses do you have? And then essentially I just pair the medications to what condition they're treating. Because the way I think of it is the easiest medication to discontinue is one that doesn't have a reason to be there, meaning it doesn't have any condition that it links to. It might have just been a remnant from an old hospital discharge or something like that. Next, I break it down by those conditions to see, is condition A being treated by multiple drugs? So, for example, if drugs A and B are being used for blood pressure, but neither are at their highest dose, I'll consider consolidating it to just one drug, but at a higher dose. I do know that more evidence is coming out to say that it's actually the opposite, that hypertension, for example, it's sometimes better to use lower doses of multiple drugs, which kind of flies in the face of polypharmacy. But in certain elderly populations, I would kind of advocate for streamlining the medications and increasing the dose of a single medication, particularly if you can get rid of a medication like a diuretic, for example, which causes, excessive urination and may be difficult for someone who has, issues getting to the bathroom quickly, something like that. So while I understand that kind of goes against some of the more common or more recent knowledge, it's still a strategy that can be taken. Now, in some cases, and this is my favorite, a patient may have 2 conditions that can be treated with a single medication. So a good example of this would be a patient with depression and neuropathic pain. So sure, you could treat each condition with their own separate medication. However, there are medications that are proven to treat both conditions, like the antidepressant Cymbalta, for example. In these cases, I will definitely recommend consolidating from 2 drugs down to 1 to kind of take a kill 2 birds with 1 stone sort of approach. And finally, there may be cases, particularly in the very elderly, in which we can kind of take our foot off the gas, so to speak. Not to say that we no longer care, it's just to say that we kind of don't push as hard. So a common example is diabetes management. So in elderly patients with many chronic diseases who are more likely to be harmed by having their sugar drop too low, we can start considering less aggressive treatment targets. In doing so, we can usually stop some of the medications, or even lower some of the doses of insulin, for example. And this can usually help our patients, again, those very, very old, very sick patients, to avoid some of the potentially serious side effects, which would be in this case low blood sugar or hypoglycemia, which can be more common in the very elderly or those with multiple chronic conditions.
So I have to ask then, and this is probably going to be very similar to the answer you gave earlier, but what are the biggest payoffs in terms of reducing polypharmacy for institutional clients?
Yeah, well, first and foremost, I'd have to say patients' well-being, and obviously, like you said, it's a similar response to what we've been discussing earlier in the podcast. But polypharmacy, just to sort of recap, polypharmacy, when it's severe enough, can obviously diminish an individual's quality of life. I mean, taking medications around the clock, possibly experiencing side effects. By optimizing a patient's treatment regimen, we can often simplify their dosing schedule and hopefully keep those side effects to a minimum. Mm-hmm. Additionally, there are some, facility-specific benefits as well. I mean, obviously, there's a cost component to it. I mean, regardless of who is footing the bill, whether it be the patient or the facility, the more medications that a patient takes, obviously, the higher the cost is going to be. So by addressing polypharmacy, we hopefully are able to help save patients, facilities, and the overall health system some money in the process. But finally, and this is something very unique to institutions and not often thought about from a polypharmacy standpoint, but it's pill call, which is the nurses administering directly the medications to the patients. And this can be quite time consuming for nursing to prepare each dose and administer to the patient. So each medication represents additional time that a facility nursing staff or that facility staff must spend preparing a patient's medication. So in a way, by addressing polypharmacy, we can actually save nursing and facility staff some time. And the way I like to think of it is this is time that they can then use for more direct patient care.
Absolutely. That is something that I hadn't thought of, the pill call end of it, the nursing time. Yeah, can really appreciate then how much polypharmacy would add to that. So That's a really astute observation. Something that you mentioned when we were talking about polypharmacy more out in the community was the notion of being your own health advocate. Now, I would assume that it's a little tougher for patients in these settings, corrections or long-term care, to maybe be their best patient advocates. So do you run into any issues with that?
I would say, from my experience, probably the hardest things that lead to it, because you're right, the patients in these settings are not always the ones carrying around a pocket card of all of your medications, whether it be that they're just unable to do so physically or mentally, or they're just not allowed to carry around stuff, be it in a correctional facility. One of the biggest instances of where it can occur is during transitions of care, where say a patient goes from the hospital back to the facility. Medications may not have been discontinued from when they were in the hospital, and they'll get continued in the correctional facility or in the long-term care facility. So these ones are harder to address than others. And it's basically because the provider at the facility doesn't necessarily know 100%. They can read the discharge reports, but they don't 100% know, that this was supposed to be discontinued. But I would say, it's important for the provider and the nursing staff at the intake facility to read through the discharge paperwork just to make sure that there weren't any mentions of a discontinuation. But it's hard on the pharmacy side because as the pharmacist, if we get an order for something, we have no reason to believe that this medication should have been discontinued unless it is a duplication of therapy and stuff like that, where it would be particularly egregious or noticeable. So in these cases, when I speak to providers in nursing, I tend to say, just be vigilant on your discharge paperwork. If you're the sending facility, if you're sending this patient out to a different facility, make sure that you do a double check on their current medications and make sure that that's correct. And for the receiving facility, make sure that you're double checking as well. Just make sure you're looking through the paperwork to see if there's anything that was supposed to be discontinued that's being continued incorrectly. So essentially, it's a long way of saying keep your lines of communication open and always double check your paperwork.
Yeah. It boils down to that in so many situations in life, but especially in healthcare.
Yes.
This is also a good place to actually plug an earlier episode of the show where we had Deborah Melito on talking about medication safety through transitions of care, specifically in the skilled nursing environment. But some of the things that you were talking about, absolutely, she expands on in that earlier episode. So do go back and check that out if that's something you're interested in. Well, Chris, I do appreciate your time. Exploring this polypharmacy issue, it adds appreciation to the idea of just the interplay involved here. It may seem very simple, like, well, if you take too many prescriptions, just take less of them. But again, how hard deprescribing is, how you explain that, and just, at the same time, how easy it can be for well-intentioned prescriptions to start piling up on one another, a la the prescription cascade. This whole issue just underscores the complexity and gives me an added appreciation for how you as pharmacists or any provider in the chain have to work together and have those open lines of communication.
Yes. And just to add, not to add too fine a point to it, but again, I just want to remind everyone that whether you're a provider, a pharmacist, a patient, a friend, or a family member. Patients can be their own advocates, keeping an up-to-date record of all the medications, all of the providers, making sure that everyone is in the loop. That way we can prevent this and kind of nip it in the bud before it happens. And this is not to say that patients taking more than 5 medications is a bad thing. I would never want to make anyone feel any type of way for that, because there are many patients out there who need more than 5 medications, who may need 10 medications, just depending on their conditions. But if it's a patient who's taking 10 medications, before immediately prescribing another medication for that runny nose, is there something that we can do to manage that runny nose otherwise, such as changing the environment, looking for allergy triggers in the house and stuff like that. There's many examples of these, but I think the general gist is just more of a judicious use. When you go to add medications, can we find other ways first before we have to go to, the clinical necessity of it.
Well, Chris, thank you once again for joining us. I'm sure you'll be joining us again in the near future for another episode, but this has been great as usual, and really appreciate you sharing your insights into polypharmacy with us.
Well, Adam, I really appreciate you having me again. I'm always happy to be here, and I look forward to the next time that you have me back.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.
Music in this episode by Wolfgang Worley. Sound Express by Getty Images. Additional music by Maximiliano Silvera, Sound Express by Getty Images, The 126ers, and Silent Partner.